Once again, a very good afternoon to all the dignitaries, faculty and delegates assembled here. Interesting topics are going on, and now one of the senior dietitian, Dr. Nancy Sahni, is here to share from PGI Chandigarh to share her expertise on the topic. So she is a senior most dietitian. She has many publications and awards to her credit. I kindly invite Dr. Nancy here to start on with the topic.
A very good afternoon, everyone. I hope you can keep your eyes open after such a sumptuous lunch, and we are talking about diet. Yes, I have been invited over here to present case-based discussion designing CKD diets for vegetarian and non-vegetarian patients, and immense thanks to the organizers to make me a part of this prestigious conference. So, everybody is well aware of this thing that nutrition plays a backbone in every aspect of CKD, from prevention or controlling the effect of some causes of CKD like diabetes, hypertension or glomerulonephritis, to the effect of the disease and its management. The diet protocols are very important. So, let us see the current trends in CKD nutrition, the paradigm shift from restriction to optimization. So, if you compare the traditional approach to modern evidence based approach, universal protein restriction was there for all CKD stages, but now it is a personalized protein prescription based on stage, metabolic status, comorbidities. Now, animal protein as a primary source of high biological value, definitely it is there, but now focus has shifted to plant protein emphasis with controlled bioavailability. Now, controlled bioavailability is using some specific processing techniques or combinations such as fermentation or germination or enzymatic hydrolysis or certain plant based food combinations like cereal pulse combinations to improve the bioavailability of proteins in the body and availability of essential amino acids. Now, before going to the case studies, let us see like it is a debate since morning, that vegetarian versus non-vegetarian diets. Something is happening to the slide. Okay. I don't know what has happened here. There is some technical person over here, if somebody can help it out. Excuse me, ma'am, is there somebody to do this? Something has happened. I don't know what's so please do not count these minutes. So, vegetarian versus non-vegetarian diets, let us see the comparative analysis. So much has been said for that. So, definitely all the protein sources from veg and non-vegetarian and plant sources provide fiber and phytochemicals absent in animal foods, whereas animal sources are high biological value proteins. Talking about dietary acid load, it is the negative PRAL, that is potential renal acid load in vegetarian diets. They are alkalinizing, whereas non-vegetarian protein sources have positive PRAL, acid producing, and all know that alkaline diets improve serum bicarbonate and slow GFR decline. Then if you are talking about the phosphorus bioavailability, it is bound form in the plant proteins, whereas it is in the free form in the animal sources. So, lower absorption reduces hyperphosphatemia risk despite similar total intake. जब हम सारा intake लेते हैं, even if it is a plant based, so it comes to the same when it is but then if you compare it with the animal sources, but definitely the bioavailability is less. So, we have to count in that also as dietitians. Phosphorus additives, whatever the food, whether it is vegetarian or a non-vegetarian diet, they are inorganic phosphorus, they are not related to the food matrix. So, it is 90 to 100% absorption and the most dangerous source of phosphorus in the CKD diet plan. Then if you see the potassium content, definitely the plant based diets are higher but modifiable via cooking techniques like boiling, leaching, soaking. If you soak the dals overnight and throw the water in the morning like rajma, chane and all, so 30 to 60% of the potassium can be lost very easily. And choosing low potassium foods, judicious combinations, portion sizes, so you can manage that. Non-vegetarian, it's variable, of course. Hyperkalemia, this is the clinical significance, simple cooking techniques reduce it. Fiber intake in a typical balanced vegetarian diet is 25 to 40 grams per day, whereas in a non-vegetarian it is 15 to 20 grams per day, and 10 grams per day increase. It reduces the CRP by 38% in chronic kidney disease patients. Saturated fats less than 10 calories in a good vegetarian balanced diet, whereas 15 to 20% calories from non-veg diet. Of course, it calls for reduced CV risk, cardiovascular risk and better lipid profile. And talking about the uremic toxins, they are lower in the plant-based diets, whereas they are higher in the higher in the animal based diets, and toxins contribute to CV disease and CKD progression. And one point here is when the fiber is more in the diet, so what happens is that it gives an energy source to the gut bacteria to utilize it and break it down into short chain fatty acid, but it diverts it, you can say, from breaking the these into the protein into the toxic metabolites. So, high fiber and plant based diets, they score bonus points in this. Lot has been said about the alkaline diets, and I can skip this slide because everybody knows about this by now if you have attended this conference right from 9:30 in the morning. And yes, the Plado diet is the talk of the town today, more than 50% of the total protein intake from plant sources. So, let us go to the case presentation. Patient profile, if you see, she is a female, 56-year-old, homemaker, North Indian, lecto-vegetarian, hypertension from the past 10 years, previously poorly controlled, dyslipidemia, and she has lost 6 to 7 kgs of weight in the past 2 months. So, if we see the clinical and laboratory data, serum creat is at 3 elevated, indicates reduced GFR, monitor trends for progression. Phosphorus is elevated, so we have to reduce bioavailable phosphorus sources. Calcium is normal, so we have to relate it with PTH, avoid calcium overload. And if you see PTH, it is elevated. Bone disease and cardiovascular risk, phosphorus control again is essential. Serum potassium high, monitor with plant based diet transition, modified cooking techniques may be needed, and check for blood sampling techniques. Sometimes if it is cell lysis, so the sample can also be faulty. Hemoglobin 10.5, anemia of CKD, evaluate iron status, and vitamin D is insufficient, supplement to reduce parathyroid hormone elevation and improve bone health. Now, let us look at the dietary intake of this female. Now, she was hardly eating. She was hardly eating in a day 2 chapatis in a day, a bit of rice, a bit of dal, a bit of vegetable, and she was having the solace in having Coke, Limca, apple juice. This was only solace in her diet. And why? Because when we probed, we came to know that she had developed food fears and wrong food perceptions about the CKD diet. So, this was one of my study when I was doing PhD in PGI many years back. There were these patients, they had developed food fears related to renal disease. The sample size was 190. And with due respect to all the physicians and of course the patient word of mouth कि खट्टा नहीं खाना, दूध नहीं पीना, हरी पत्ते वाली सब्जियां नहीं खानी. So what happens is that people, patients, they develop food fears. खट्टा मतलब दही भी नहीं खाना, हरी पत्ते वाली सब्जी, everything green in vegetable, पत्ता तो भूल जाते हैं. So of course they can also be added to certain extent, and some are low in potassium. So they don't have it. So where will the protein come from? Even they do not have fat कि उससे गुर्दे खराब हो जाएंगे. So you know, where will the energy come from? So the intervention strategy first and foremost was, the phase 1 was the prior 2 weeks, education and behavioral changing strategies, eliminate lack of knowledge about the CKD diet, food misconceptions, food fears, that was very important to do, and introduce the exchange system, the energy exchange system, the protein exchange system. 200 ग्राम दूध में अगर इतना है, 35 ग्राम पनीर में भी सेम प्रोटीन है, 6 ग्राम, एक चपाती में इतना है तो एक कप दलिया में, एक कप उसमें कितना है. So I mean all these she was taught. This is very important, the first step. Then the second phase is from week 3 to week 8 is dietary modifications. Add optimized dairy products, eliminate phosphorus additives from processed foods. Like she was not aware of the fact कि Coke is rich in you know, phosphorus, and she was aware of the fact that apple is low in potassium, so she was having apple juice. So it's not being illiterate, it's being unaware. And add controlled soy and legume portions and complete protein profile cereals. Some cereals like buckwheat, quinoa, and they have a complete amaranth, they have a complete essential amino acid profile, so we can add that. Implement daily fruit and vegetable targets and fine tune the portion sizes. And then the phase 3, that means month 3 onwards, maintenance and optimization. Dietitian follow-up monthly with biochemical review, and quarterly comprehensive nutritional reassessment, body composition analysis. So the diet was like planned at around about 1500 to 1700 kilocalories and 40 grams of protein, not less than 0.8 grams per kg per day, because you know she was already emaciated. So so you see, we added so much of variety in the diet: energy, fiber, micronutrients, eliminated phosphorus, added improved quality protein. You know, so and to top it all, the patient was very happy with that. She was like, you know, it was that food depression had gone. So she because you know food is related to emotions, feel good factor. It did help this patient to regain strength, regain her food confidence, her hand grip strength improved, and her serum levels of some things also, and improved, and the quality of life based on KDOQI short form, that also showed improvement. So let's see the case 2. He is a male, 92 kg, 6 feet, 59 years old, chef and a small restaurant owner, Punjabi family, non-vegetarian, die-hard non-vegetarian, social alcohol consumption, type 2 diabetes, hypertension, diabetic retinopathy, laser treatment done. And let's see the diet history now. Now, this fellow was having non-veg every meal, 2 eggs, breakfast, then lunch butter chicken or mutton curry. Evening he was having tea with jaggery or honey, because he was saying I am a diabetic, I don't add sugar. And alcohol, when he was not having tea, he was having alcohol thrice a week with tikkas and honey chili cauliflower kebabs. And dinner was again biryani, I mean most of the time. So high in saturated fats, high in sugars, phosphorus, high in you know, fried foods, refined, animal protein, late heavy meals. So if we see the problem, the protein paradox, it was like almost twice what was required. Animal protein excess was there, so we have to shift to plant protein sources. Phosphorus trap, there is a cardiovascular risk, calcification risk, so plant phosphorus 40% absorbed than animal, so we again shift. Then silent acidosis, so you know, all this muscle wasting, bone loss, GFR decline, accelerator, inflammation, because CRP levels were high, so fiber boost is required. Then uncontrolled diabetes, HbA1c was 8.2, carbohydrate intake was more than 350 grams per day, that too from refined sources. So optimized glycemic control. Then this UACR was high risk for rapid progression, cardiovascular events. And diet misconceptions: jaggery honey is not sugar, diet coke is safe, and green vegetables harm the kidneys. So he had these diet misconceptions, so they had to be taken care of. So, the quantitative analysis is this, and the patient quote was that I am a chef and in food business, food is my life, my customers expect me to cook well, therefore I have to experiment with new dishes and taste them. So, what to do now? So, the intervention strategy was to halve the protein amount, non-veg frequency, it was like minimum twice daily. So, once choose lean chicken cuts, fish, egg whites, watch portion size. Then cooking method was like butter chicken, fried kebab. So, it had we tried to change it to tandoori, grilled, stewed egg whites. Fat base from ghee, butter to mustard oil or olive oil. Then carbohydrates we tried and shifted to the whole ones and with complete amino acid profile, vegetable and fiber minimal, it was there. Now 3 cups daily lightly cooked raw. So, we also added psyllium husk in the diet at night and also a fiber supplement before lunch. Sodium was too high, so it had to be optimized. उसको समझाया गया था 2 ग्राम सोडियम मतलब 1 चम्मच पूरा teaspoon of salt is not less, it is not less. If it is, and everybody should have, we should have this, not more than this. And if we are not having processed items or any masalas or papas, and it is not a rocket science to do this much of a restriction. And use of herbs to flavor the food, and of course not to use low sodium salt, that was also emphasized, and foods to eliminate diet coke, jaggery, alcohol. So, that was there. So, after 12 months the EGFR stable at 38 ml, no hospitalization, continuous modified diet with 80% adherence, blood glucose control better. Then what were the key success factors? Occupational integration, made diet changes, part of the business innovation. In fact, he said that his clientage has improved after all these innovative recipes. Then cultural preservation, maintain non-vegetarian tag. He was not told to change to a vegetarian diet or a vegan diet. So, that was maintained, that he was still having a, because then there cannot be a compliance, and it was not required also. Family involvement, wife as co-creator of new recipes, you have to involve the family. Only patient cannot do it. It is so depressing अगर आपका खाना बिल्कुल अलग से बन रहा है, बिना नमक के बन रहा है, उबला हुआ बन रहा है. Who is going to eat it? We all are humans. I mean, we have emotions and feelings. How can you be separated like this? Then flexibility, 80% of adherence with planned ingredients, and medical monitoring, monthly labs first, then 3 months, then quarterly. So, basically it is optimization. Optimization is the key. Protein source diversification, bioactive compound preservation, phosphorus control, sodium control, and potassium management. So, key feature is optimization. So, clinical significance and practice implications, they are that from restricting everything to optimizing diet quality, and of course highlights the need for routine dietitian involvement and monitoring. So, what we did in PGI after this case on a renal day. So, like I was actually pushed for this by this case that we did a kidney friendly competition, this recipe competition, and Dr. Manish Rathi was a judge in that, and we did I mean quite a lot of these recipes, more than 80, and practicing what is preached in PGI Chandigarh, and we have come up with a book. It is in the making. This is a Plado in practice. So, it has vegan, lacto-vegetarian recipes, ovo-vegetarian recipes, lacto-ovo-vegetarian recipes, flexitarian and pescatarian recipes. So, it will be soon out. Thank you.